So I'll start with the case study. This is a 62-year-old patient with history of hypertension. He is, for full disclosure, he's my uncle. And he is suboptimally treated. He often denies that he has hypertension, he has diabetes, and hemoglobin A1C varies, and he insists he can reverse it with food, diet, but he does like sweets. He's reasonably active, walks about 3 to 5 kilometers per day. He's politically active, a lawyer, and he's quite excitable with all the political conversations. And he's had occasional discomfort, chest comfort for years, and he would take famotidine and would get relief. So he did have testing some time back, which was negative, which he had an EKG, echocardiogram, and a stress EKG. Now, however, recently he reports that some episodes he's been having slightly different in characteristics. They're mild, and particularly happen with agitating discussions during political conversations. But insists it's nothing. However, I keep getting phone calls every week. So what is the initial diagnostic test one should do at this point? These are the following options. He's had workup, so we could do nothing. Repeat an echocardiogram, repeat an EKG stress test, stress echoes, or stress perfusion, nuclear and CMR, cardiac MRI, or we can do a coronary CTA. And before I go and tell you what we did, I think this is a good point to discuss what the recent guidelines that have come from ACC/AHA in 2021, how to evaluate chest pain. And for this purpose of this topic, I'm going to only focus on the stable category and not on the acute chest pain category. So we have this nice diagram, pictogram, which shows all the different categories of risk: asymptomatic, low, intermediate, and high risk, and the different diagnostic algorithms. And I'm going to go a little bit more into detail on that. Now, before we determine which test, the first thing you want to determine is the pre-test probability. And oftentimes, most of us seasoned clinicians will do it by experience. However, there are good risk calculators that are easily available online. And the guidelines recommend that diagnostic testing be reserved for moderate and high risk pre-test probability, and not so much for the low risk probability. Now, if you do consider patients as low risk, then you do not need to do any additional diagnostic testing, and it can be deferred. Alternatively, you can also do coronary artery calcium scoring as a first-line test to risk stratify. Additionally, exercise testing to determine the functional capacity is also recommended. Now, if you're intermediate to high risk, the latest guidelines actually give level 1 recommendation to coronary CTA for diagnosis of coronary artery disease and risk stratification. The usual testing that we do, stress imaging, whether it's by stress echo or stress nuclear or cardiac MRI, still has level 1 indication. And there are other nuances that I won't go into detail. I'll defer to the article itself. Now, so if you have an intermediate to high risk patient like my uncle, exercise echocardiography, electrocardiography, that's what he had, is a reasonable test, but it's really not the optimal one. It has a 2A indication. Level 1 is either stress testing or coronary CTA. And a couple more slides about secondary diagnostic testing, meaning what happens if your index test, whether it is a CT or a stress test, is positive or inconclusive. So the new guidelines recommend that you can do FFR-CT for those cases where you have moderate stenosis, moderate to severe stenosis, to understand their physiological significance. And you can also, if you have an inconclusive stress test, you can also do a cardiac CT. So they also give you a lot of room, the new guidelines, in case you have a negative stress test, but your clinical suspicion is really high for coronary artery disease, then they give us the option to do either a cardiac CT or directly an invasive coronary angiogram. That's in 2B, the bottommost slide. I won't go into the details, but there's a nice pictogram here within the guidelines which tells you which pathway you can go based on the risk, whether it's low risk, intermediate risk. and which pathway. And of importance is like CT and stress testing have equal significance in the new guidelines. Now, you have all these testing, so which one would we perform? And if you look at all the sensitivities and specificities, and your goal is to detect high-grade stenosis, then CTA is the best diagnostic test for diagnosis of high-grade stenosis, particularly in those who are less than 65 years old. And just to mention that in most of the studies, also cardiac MRI fares very well, stress perfusion study, the main constraint being the availability and lack of expertise, but the test itself is very good in terms of diagnosing. Now, if you look at the diagnostic testing for with CT, CT detects it before there's functional abnormalities. You detect plaque as well. And choosing the right diagnostic test, if your pretest likelihood of coronary artery disease is intermediate to high, and your idea is you clinically suspect less obstructive coronary artery disease, then you prefer CT. And if you think that there is ischemia, then you do stress testing. Again, I mentioned the age of less than 65 favors the use of CTA. And depending on if you need other functions, you can choose the different kind of stress testing. For example, if you need scar information, you might be looking at cardiac MRI or a PET scan. Or if you're looking at flow reserve, you might be looking at a PET scan or a cardiac MRI. So what did we do with my uncle? I had sent him for a coronary CTA. He had very high calcium score, but the cardiologist called me and he said, since he has so much calcium, we can just directly go for an invasive CAD. And that's what happened. He had an invasive CAD because of his high risk features on the calcium score. And he indeed actually had triple vessel disease in the LAD, RCA, and diagonal. And he ended up getting a coronary artery bypass surgery after discussion of all the treatment options. He's recovering well, and he has a marked change in lifestyle and is taking all his medications and statins, so he's doing quite well right now. Now, I did mention about the FFR CT. I understand it's not available in India at this time, but this is a technology that is being widely used or increasingly used in the US, and it is a AI, artificial intelligence-enabled technology that combines information algorithms from deep learning, from the CT data, and manual analysis to give the physiology information. And and it doesn't require any additional medications. It uses the data that is already acquired. Here's an example. This is a patient. You can see the CT images of the coronary arteries, RCA, circumflex, and the LAD. And in the LAD, you see that in the mid portion, it kind of looks, it could be significant or not, we're not sure. So the CT-FFR actually shows a clear stenosis in the LAD lesion, and you see that also confirmed on the diagnostic cardiac catheterization. So we have evidence from 2016 that the FFR CT is reducing the number of CATs and increases the efficiency of catheterization. So I just want to touch upon this trial called the PRECISE trial that was recently released in the AHA conference. And essentially what it showed was when you look at the PRECISE approach, meaning using CT-FFR, and a new risk score called PROMISE risk score versus traditional testing, or traditional stress testing. And they looked at the composite endpoint of both cardiovascular events and the unnecessary cardiac catheterization. And if you look at it, the precision pathway, which used only CT and CT-FFR, and the traditional testing, which is more representative of our current practice, if you look at it, the precision pathway actually significantly reduced the 70% reduction in the composite endpoint, meaning we get, there's no, it is safe to do it this way, and you actually reduce the need for unnecessary cardiac catheterizations. And this is what these slides are showing is that the patients have a more effective, less number of cardiac catheterization, more number of procedures, so your cath yield is high with the PRECISE approach. So in summary, an anatomic testing with cardiac CT has a preeminent role in 2022. Add-on physiology testing, FFR, improves specificity and reduces downstream testing. Functional testing is particularly helpful to evaluate ischemic burden and prognosis. And CT is rapidly emerging as a one-step choice. And further refinements in risk score and CT-first strategy improves precision. So thank you.